Good morning again, and thank you for having me back today on day 3. So again, I'm going to open with a little bit of information and background from the Point Prevalence Survey that we conducted here at CDC in 2017. And the data that I'm presenting to you today is going to focus on antimicrobial or mainly antibiotic use and kind of help provide some data to have you thinking about how antibiotics or antimicrobials might be used in your facility and moving towards the realm of stewardship and how antibiotics are used and used appropriately. So just as a reminder to you all, the second primary objective of doing this large-scale point prevalence survey in nursing homes was to understand more about how antimicrobial drugs are used in nursing home residents. And if you go to the literature and look at research and studies that have been done on antimicrobial use in nursing homes, there's really not a lot of large-scale information that comes out of the United States. So a lot of what we have learned so far has come from smaller studies or from studies that have been conducted in other countries. And so some of the data that you will see here today, I think, is really quite unique in that it's large scale. It comes from a wide range of nursing homes based in the United States. And some of this data has only just recently been shared. We had a couple of professional meetings earlier this year and late last year. So other than people that attended those professional meetings, you as the audience here today are among the first people to see some of this data. And it will be coming out, we anticipate, in a publication later this year or early in 2020. And I will say our colleagues in NHSN often use that newsletter that you just heard about to bring attention to this type of work. And so signing up for those newsletters can help you learn more about this type of work that's being done by CDC in nursing homes that isn't part of NHSN, but is directly related to healthcare infections and antimicrobial use in nursing home settings. So just to help you understand a little bit more about how we measured antimicrobial use in the nursing home settings for this point prevalence survey. So we looked at what we called and defined as systemic antimicrobials. And basically, in order to be counted in the point prevalence survey, if a resident was in a nursing home that participated in the point prevalence survey, and on the day that the survey was conducted in that particular facility, and they were receiving a systemic antimicrobial drug, then we counted it, okay? And so the types of information we received for each drug that was received by a resident at the time of the survey included the name of the drug and the drug class that it falls within, how the drug was administered to the resident, the rationale. So this is at the time that the prescription was written, what was the provider giving this drug for? Was it to treat an active infection or a suspected infection? Was it for prophylaxis? So sometimes we see use of drugs and antibiotics to prevent an infection that hasn't yet had an onset. And we also see occasionally, not often, but occasionally drugs, antibiotic or antimicrobial drugs that are given for a reason that is not infectious for another reason. We also collected information on the therapeutic body site. So where was the site of the infection that was being treated or attempting to be prevented? And then we also collected information on the first date, so the date that the drug was intended to be started, and the end date when it was intended to be stopped, so we could get a sense of planned duration. So by systemic, we define this as being by the oral or enteral route, intravenous, intramuscular, or inhaled. And just to be clear, we excluded drugs that were given by the topical, ophthalmic, otic, and intranasal routes. And then for antimicrobials, we had a list of 130 different drugs that we were interested in. They're mostly, by and large, antibiotics, but it did also include a couple of antifungal and antiviral agents. But by and large, when you hear me today saying the word antimicrobial, we're really looking at antibiotics that we used. So the prevalence of systemic antimicrobial use in nursing homes on a given day in the survey that we conducted among the 161 nursing homes, 15,276 residents, was 8.2%. So 8.2%, if we think about what that means per 100 nursing home residents. In other words, that is the number of antimicrobial, about 1 in 12 residents in nursing homes on a given day were receiving a systemic antimicrobial drug. So that's interesting information and important information to know. But what does it mean? I think it's really helpful to have some perspective. Is that high? Is that low? Is that good? Is that bad? And one way we can get some of that perspective is to look at other studies that were done using similar methods, so the point prevalence survey. And fortunately, we can know that in the United States, while we were conducting this point prevalence survey in nursing homes, there have been other point prevalence surveys that were done in U.S. acute care hospitals. And we look at, on a given day, what percentage or what is the prevalence of patients in an acute care setting that are receiving a systemic antimicrobial defined using the same way. It was 49.9%. So almost half of patients in an acute care setting on a given day are receiving a systemic antimicrobial. So as you can see, many times higher than what we're seeing in the nursing home setting, but probably not unexpected given the types of patients that are in an acute care setting, and that one of the main reasons for being in an acute care setting is often to receive systemic antimicrobials. So that's one comparison point that we have to understand, well, what does 8.2% mean in nursing homes? Another place that we can look to, which may or may not give us a better comparison, is the prevalence of systemic antimicrobial use in nursing homes in Europe. And so, as I had mentioned previously, also the European CDC has a long history of doing one-day point prevalence surveys across long-term care facilities in Europe. And they have conducted 3 of them, and they have measured antimicrobial use using the same approach that we did, looking at systemic antimicrobials. So in Europe, the prevalence of antimicrobial use in nursing homes there has been consistently around 4 to 5%. So in the first survey they did, it was 4.3 in 2010. And most recently, the survey that they completed in 2016, the prevalence was 4.9. So you can see, depending on which year you pick, in the United States, we see approximately double the prevalence of antimicrobial use in U.S. nursing homes compared to those in Europe. When we look at how are drugs administered to residents in nursing home, it's probably not surprising to most of you to see this green bar here. It represents the oral administration. So almost 80% of all the antimicrobial drugs that were received at the time of the point prevalence survey were via the oral route. We had a smaller proportion, not quite, just over 10% that were intravenous, a very small proportion that were intramuscular, and a teeny sliver that were inhaled. So most antimicrobial drugs in nursing homes being administered by the oral route. When we look at the rationale for treatment, we look at, again, this is at the time that the drug was prescribed. Was it being given to treat an active infection? Was it being given for prophylaxis to prevent an infection? Or was it being given for some other non-infectious reason? So here you can see, again, almost 80% of all of the antimicrobials that were received at the time of the point prevalence survey were being given to treat an active infection. So this is an individual that is displaying some type of signs and symptoms, and the provider actually has some laboratory testing or other clinical information that confirms to them this person does have an infection, or it's that they suspect that they have an infection because they're showing signs and symptoms, so they're prescribing an antimicrobial. We have a relatively large proportion there in orange that was for medical prophylaxis. So that's to prevent an infection. A smaller portion that were for non-infectious reasons, and then a very tiny proportion that at the time that the records were reviewed, the person reviewing the record wasn't quite able to tell what the rationale was. When we look at the top antibiotic classes that were used here, I want to draw your attention to the bar at the bottom that represents fluoroquinolone. So just over 15% of all of the antibiotics that were prescribed and identified as part of the point prevalence survey were a group of drugs called fluoroquinolones. And I will not spend a lot of time talking about this, but I wanted to bring your attention to this because there's a lot of evidence that suggests that the use of fluoroquinolones can induce multi-drug resistant organisms, and as you had heard yesterday, is also maybe responsible for causing Clostridioides difficile infection. And so again, drugs being used here that may have some adverse effects. And now finally, I want to show you the percent of the antimicrobial drugs that are being used by their treatment site. And again, I'm going to draw your eye to the very bottom bar here, which says urinary tract. So of all of the antimicrobials in this survey, so 8.2 per 100 nursing home residents was the total prevalence. Almost 1/3 of all of that use was documented to be for urinary tract infections. And again, and just to remind you, as we talked a lot about surveillance definitions for urinary tract infections. So this is just people that were prescribed a drug and it was documented to be for the treatment or prevention of a urinary tract infection. This is not UTIs that met an NHSN or a Weiss-Mageer surveillance definition. So far and away, urinary tract infection in this survey was found to be the number one cause, the number one reason for prescribing an antimicrobial drug. And I think that we can look to other studies that have been done and other surveys that have been done that tell us the same thing. So urinary tract infection is a leading cause of antimicrobial use in nursing homes. So there has been work done in Canada that has been published and looked at antimicrobial use. And when they looked at what were the most common infection types that were documented for when an antibiotic or an antimicrobial was prescribed, number one was respiratory tract in Canada, and number two was urinary tract. When you look at the figure with the colors in it, I want to draw your attention to the blue bars in the middle. And this is the European CDC Prevalence Survey that was conducted in 2013. And it looks, basically their survey showed a similar thing. We had, in the US, it was about 1/3 of all antimicrobials were used for urinary tract. Here in Europe, it was almost half, 48% of antimicrobials being used for urinary tract infections. And I think it's always helpful to have these figures out there to know that, 1/3 of antimicrobials or 1/2 of antimicrobials are used for a certain indication. I think what's more helpful at the facility level is to understand, well, what's the variation look like at the facility level for use? And we know that when we see a wide distribution, like I'm showing you in this figure, across the bottom, you have the prevalence rate of antibiotic use for urinary tract infections per 100 residents. And each of these is showing what the individual facility prevalence of antibiotic use was. So we have a relatively large proportion of nursing homes, 25% of them, that had a prevalence rate for antibiotic use for UTI of less than 1 per 100 residents. Remember that overall, the mean was 8.2. We have 50% of nursing homes in the middle here that had a prevalence rate of antibiotic use for UTI that was between 1 and just over 4 per 100 nursing home residents. And then we have 25% stretched out here in the tail that had a prevalence rate anywhere between 4.3 per 100 residents, all the way up to over 13 per 100 residents. So this shows us that there's a lot of variation in how nursing homes are prescribing antibiotics for urinary tract infection. And as we talked about yesterday, some of that is likely to be due to what types of residents you have in your nursing home and what type of risk factors they may have for acquiring infection or needing a prescription for an antibiotic. I think the other thing to consider here is a lot of the data has shown to us that there is actually a lot of provider preference that plays into what a facility rate is like for antibiotic use, and that certain providers may have a preference for giving drugs under certain conditions, and that may influence what your facility rate of antibiotic use is. And again, just to point out to you, looking specifically at urinary tract infections, when we looked at overall what was the most common type of drug that was given for all antimicrobials, it was fluoroquinolones, and here specifically for urinary tract infections, a preference here for selecting fluoroquinolones for treatment of urinary tract infection. And as a reminder, this may be associated with some type of adverse events. And is something to think about as part of a stewardship program. So finally, for the data on the antibiotic use prevalence, I just wanted to remind you again that receiving an antibiotic for UTI is not the same thing as meeting a surveillance definition for a urinary tract infection, whether it be NHSN or revised McGear. And that what I have just shown you is that there's a lot more prescribing for antibiotic use for urinary tract infections in nursing homes than there is for actually urinary tract infections that meet a surveillance definition. And so as we had talked about yesterday, I think sometimes there's a lot of concern or pressure or feeling like a need that you want to report something to NHSN because a physician may have diagnosed a UTI in a resident, or a resident may be receiving an antibiotic for treatment of a urinary tract infection. But really for NHSN and for any surveillance program, we really want you to think about and focus on, does this individual meet the surveillance definition for a UTI event? I did want to just spend a few minutes talking to you a little bit about some of the data that we collected as part of this one-day point prevalence survey on antibiotic stewardship. So if you can cast your mind all the way back to Tuesday morning, which I know now seems a long way away. But one of the pieces of data that I had told you that we collected as part of this survey was a facility survey. And we had facilities report to us characteristics about their nursing homes. And some of that data was about their antibiotic stewardship programs and whether they had one in place or not. And if they did have one in place, they told us what types of antibiotic stewardship activities that they were engaged in. And so here I can give you a summary based on the data that we collected on antibiotic stewardship. And the questions that we collected data on and asked nursing homes to report to us were based on the core elements of antibiotic stewardship for nursing homes. So this is a document that CDC has put out and helps provide a template and a guide for nursing homes that may be wanting to implement stewardship activities for antibiotics. And within this document, there are 7 core elements, which are groups of activities. And then within each group, core element, there are different activities that you can do to attain meeting the goal for that particular core element. So the data that I'm going to show you now is broken down by each of the core elements. And we'll give you a sense of, among this group of 161 nursing homes, how were they doing with respect to stewardship practices. So the first core element is called leadership. And the question that we had asked is, does your facility have written statements from leadership in support of improved antibiotic use? So only about half, 48% of nursing homes reported that they had written statements of leadership report. When we look at tracking, this is about whether you're reviewing data on antibiotic use or within your facility. So we had asked 2 questions on tracking. So do you review antibiotic use and resistance data in quality, performance, or improvement meetings? So the majority of people reported that they did there, 84%. And do you routinely receive reports on antibiotic use from your pharmacy service? 76% reported that they did. When we looked at the core element accountability, Does the facility medical director receive antibiotic use data? That was about 75% of nursing homes reported they did this. And then is an individual responsible for overseeing activities to improve antibiotic use? So about 68%, just over 2/3 of the facilities reported that was in place. With respect to the core element of reporting, we collected information on, does your facility receive an antibiogram from the lab? About 3/4, 75% reported that they did. And then for reporting, do you provide feedback on prescribing practices to medical personnel? So just over half of nursing homes reported they did that. We asked questions about the core element related to drug expertise. And this was, do you have access to either a pharmacist with ID stewardship training or an ID physician to provide guidance on stewardship? And we had 71% and 43% for each of those. For education, do you provide training on appropriate antibiotic use to nursing personnel? With 73%. You provide education to residents and their families about antibiotic use, was lower at 66%. And then the last two are in the core element called action. So we had 4 questions here, and these were various actions that nursing homes can participate in as part of a stewardship program. So does the provider require to document dose, duration, and indication for antibiotics that prescribed? So interestingly, 89% of nursing homes told us that they did this. But when we actually look at the data on what was documented, we can tell that not everyone was doing this in every scenario. Facility provides antibiotic use for treatment guidelines. So about 60%, 59% of nursing homes have some type of treatment guideline that they follow. In Action 2, does the facility have a formulary of antibiotic agents and prescribing restricted to the use of these agents? So only 25% of facilities reported that they have some type of restricted prescribing for certain types of drugs. And then is the provider required to perform a timeout? So this is a break 2 or 3 days after the antibiotic was first started to make sure that the antibiotic that was given remains appropriate and is for the correct duration. So only 25% of nursing homes reported they did that. And so what we did for each of these questions to look at how nursing home stewardship programs have been put into place, we provided a score to each question. And for each nursing home, we were able to develop what we called a stewardship score, which could basically range from 0 if you answered no to all of those 15 questions, and up to a maximum of 15 if you reported yes to all of those questions. And what we found is that on average, the median value for the stewardship score was 9 out of those 15 items. But we found that 25% of nursing homes had a score that was 7 or lower. And we found that 25% of nursing homes had a score that was 12 or higher. So again, what I'm showing you is that there's a lot of variation in how nursing homes have implemented stewardship. And I think it's important to recognize that stewardship programs and activities are relatively new to nursing homes. And while we can see here that some progress has been made, there's still some work to be done. So in summary, for the antimicrobial use data from the Point Prevalence Survey, the things that we have learned so far are that antimicrobial use prevalence in U.S. nursing homes was 8.2 per 100 nursing home residents. So that means, or translate to, on a given day, about 1 in 12 nursing home residents was receiving a systemic antimicrobial. So this is much lower than the 49% that was seen in U.S. acute care hospitals, but it is approximately double the prevalence in European long-term care facilities. Most common antibiotics were most commonly given for urinary tract infection, and that represented almost 30% of all the antimicrobial use that we identified as part of this survey. And that use of antibiotics for urinary tract infection varies across nursing homes. And what we saw is when we looked at the individual facility rates, there was a 10-fold variation in the prevalence rates. but it's important for you to remember that antibiotics that are given for a urinary tract infection are not the same as a UTI event that are reported for surveillance purposes. And finally, one of the other pieces of information that we gleaned from doing this work is that the CDC Core Elements for antibiotic stewardship are being adopted by the nursing homes that we looked at, but there are opportunities for improvement that remain. So on my final slide, I'm going to once again acknowledge the 161 nursing homes that participated in this work. And without them, this important data that we're able to collect and share with you all today wouldn't exist. And then also thank you to our EIP staff that really went out into the field and into these nursing homes and worked with them and did the data collection. So with that, I'll say thank you, and I'm happy to answer any questions that anyone may have at this point.
I have a question. Why do you think the rate of formulary use or timeout was so low, and could you comment on those?
So I think I'll answer this question. There may be others that want to contribute to it. I think the concept of implementing the timeout is a very sophisticated concept, and it's difficult to do. It's a process of care. So I think it's something that a facility needs to build into their infrastructure and requires someone who is busy and wrote the prescription to come back and look at lab results that may now be available that weren't available when you wrote the drug, or other documentation of signs, presence of signs and symptoms that may cause you to change or adjust what it is that you prescribed. And I think it's probably because it's quite a sophisticated activity that needs to be built into the process of care. I think that this is doing timeouts when we have looked at, the same types of questions or the same types of data from the acute care setting. Implementing the timeout has also been more difficult to do. But I assume, or I would like to think that stewardship activities are relatively new to nursing homes. And once nursing homes become more aware of the need for this type of activity, then they can start thinking about how can we build this into our process of care. I don't know if anyone else has anything to add. The formulary, I'm not sure about that one. I think when we do these surveys, we try really hard to make sure that we write the questions in a way that people understand what it is that we're asking them. And I think it could be that there may be some misunderstanding in what the question is asking. It could be that nursing homes rely on pharmacy services to provide their drugs for them, and they may not have engaged with that pharmacy service to think or talk about, should there be some drugs on this list that are available to us that should be restricted because of known or risk of adverse consequences. So again, I think that's one is a facility policy that needs to be made and done in conjunction with whomever is providing your pharmacy services to you. And two is, again, I think probably an activity among those that we look at for core elements that is more sophisticated than others.
Yes, my question is if the CDC can help create antibiograms by states per region, so it can help to guide the prescriptions to the clinicians.
Yeah, no, that's an excellent question. And the CDC does provide some antibiograms by state and region. A lot of that data that feeds into those antibiograms is data that comes from the NHSN. And for the acute care world. So if you go online, there's a CDC Patient Safety Atlas. And that takes a lot of the data that comes into CDC and provides information on, for certain bugs and drugs, what is the susceptibility of these bugs to these selected drugs. So most of that data comes from the acute care hospital world because they're the bulk of reporters to the NHSN. Getting that data on susceptibility is really contingent on people participating in NHSN and reporting that data. And I think this is really a plug for you all that are participating or maybe thinking about participating in NHSN. The more data that people feed in and share with us, the more things that we can do with that data, such as creating antibiograms for your region or your state. But right now, for the nursing home setting, I don't think that there's sufficient amount of data or information available to provide regional or state level susceptibility data. But yeah, it does continue to be a challenge to provide that information. I think that whomever at your facility level, whether you work with a laboratory service provider, you can have some discussions with them about generating antibiograms either for your facility, which may not always be very helpful if you have very small numbers of cultures or residents, but may be able to help work with you to provide something more regional or state-based that could be informative.
I'm sorry, I may have missed this at the beginning, but how did you, on the antibiotic stewardship, what was the process where you talked to these nursing homes? Like, did you just do a phone interview and then just ask them this question and wait for the answer?
So we had a standardized form that we had created that was based on the questions that are part of the CDC Core Elements document. And we wrote those in such a way that the nursing home would self-report. So they received a standardized form, and they had a couple of weeks to complete that form. They were able, we asked the director of nursing who had the form to go around to your facility and all the different players and help answer these questions so you get it right. We structured the question so that people could give us, yes, we're doing this, or no, we're not doing this response. So it was self-reported data, and I think when anybody does a survey and collects opinions on self-reported data, you can always assume that what people are telling you and what is actually happening may not be entirely correct. And as I alluded to, we did find some evidence of that where nursing homes were telling us, yes, we always have our providers document the rationale for giving a drug, the treatment site, an end date, and a start date. But when we actually look at the data that was collected from the charts, we know that it wasn't infrequent for pieces of that information to be missing. So I think in order to take some of this work even further, it's helpful to do some type of validation or to be in there and really talking to people about what they're doing for stewardship rather than respond to yes, no questions. Thank you, everybody.